Hello everyone, how's my coding family doing today? Can y'all see the screen? Let's see if y'all can see and hear things yet. Yay, that's wonderful. Hi Alvin, hey Elizabeth, hey Holly. You're taking yours on the 22nd. Practice questions. Practice questions. That will be the best use of your time. As many questions as you can find. How you doing, Elizabeth? Hey Holly. Hey Tabor, good to see you. Hey Kath. I'm about to schedule my exam, hopefully next week. Your third take, third time's charm. You know that, Kath. Hey Erin, good to see you. Hey Jess. Hi Ibis. Hey Holly. What state is everybody from? Just curious. Hey Jamie, good to see you. Hey Elizabeth. Thanks for letting me know you can hear and see the screen. Yes, yes. Erin is Brenda. Hey Jennifer. She says, hello, coders. Hey Crystal. Hey Marlene. Hey Rosa. Hey Johns. Hey Diana. Hey Marcy. Taking your exam on the 31st, third time. Hey Rosa. New York. Alabama. We got Louisiana in the house. Cali. We got Texas, another Alabama. Hey Elizabeth, Callie, Lisa. My two youngest children were born in Ohio. My oldest was born in Tennessee. I was born in New York. We're a hodgepodge of stuff. Hey Jill. Philippines. I have some really good friends in the Philippines. Well, one lives in Australia now, but they were children. They grew up in the Philippines and now they've finished college and living their lives. Yay, that's great, Jessica. Jessica says she's been enjoy watching and she's going to decide to go into medical coding. Awesome. In Mississippi, I used to live in an area called Bullfrog Corner at Lake Forest in Mississippi for many, many years. Let's see, probably second grade through seventh or eighth grade. I lived there in Lake Forest in Mississippi, very, very close to Memphis. Hey Megan, Texas. First time joining the live. You test this weekend. Ooh, Megan, I got some good info for you then. Hey Crystal. Thank you. She likes my videos. She loves my videos. That's awesome. You're fixing to take yours. Awesome. Hey, Brenda. Oh, yeah. Aw, no worries. New York. I was born in an Air Force base in New York called in Rome, New York. I don't know if it's still there, but hey, Bright Farms, Florida. Hey, Crystal. Thanks, Jaybird. I appreciate it. Bullfrog Corner. That's right. It does sound like a children's book, but I think it's a lot different now than it used to be. When I lived there the whole time, maybe towards the end we got some more houses, but we only had 12 houses in our neighborhood at Lake Forest. So it was a great little neighborhood. I used to ride my bike up to Bullfrog Corner and get eggs or milk for Mom. But now I'm sure no one could do that. Arizona, me and Rach. All right, y'all got hit me up with your questions. Anybody got questions for me today? Any codes y'all want to look at before we get started with what I've got? I've got E&M. No, I've got Lab and Path. I have 2 more of those left over from yesterday or Wednesday's live. And then, so I've got 3 more actually, I think, somewhere around there. Lab and Path. Then I've got Musculoskeletal and E&M and some ICD-10. So it was a great place to be raised. It was kind of lonely. I was an only child though, and my parents worked in Memphis, so they left, before the sun came up, and then they came home as the sun was going down. And I was kind of, I didn't have any kids with me, so I didn't know how to make friends with other kids. So I just played with the turtles and the frogs and the lizards and the roly-polies and the geese, and rode my bikes. Or my dad made me a moped. He made me a go-kart. He was always making all kinds of stuff on the weekends. But when my parents weren't around on the weekends, it was kind of lonely during the week, but it was still great. I should have had a little bit more kids around so that I could have learned to interact with people better, because I struggled in school because I didn't know how to hang out with the other kids. I don't know why. That's weird. I guess it doesn't come naturally to some people. First time observer in Georgia, but researching. Yay! Awesome. I hope I can help you out. You're very welcome. You want to get the ICD-10 notes? I love my ICD-10 notes. I like them. I moved all the guidelines to them and put a ton of examples there. And it's fun to do because it's not like a whole coding page and set. It's like examples. Like you only go do OB and pregnancy near the OB and pregnancy codes. And then you can move and go do the hypertension ones or the sepsis ones or the burn ones. So it seems like it's faster than coding an entire or prepping the entire CPT book. That's an ordeal. Good gracious. All right. You're testing on the 22nd too. Migraine? I'm sorry, Jessica. All right, let's see. I'm looking at a CPT code for this scenario. My kids with an extra pinky on both hands. Yep. And one's formed and the other a little nub. They are being removed. I've seen that question before. I don't know if it's a real scenario with you or if it was a practice question you're working on. But yeah, I've seen that question. You're looking for the CPT codes for that? I did a lot of OB and peds in my clinical time in medical field, and we would just take a piece of suture string and tie off the little nubs, and then they would just fall off unless it had bone. If it had bone, then we had to refer to orthopedics for surgery removal. Let's see. We'd probably be in musculoskeletal. We'd probably be around, let's see, where am I at? We're going to go over to repair, revision, and reconstruction of fingers. So around the 2635, where are we at? What about 26587? I like that one. That CPT code. We've got a polydactylous digit, soft tissue and bone. If you do just the soft tissue in the office like I used to do, we tie it off with suture or whatever, you could use an integumentary code, 11200, according to the parenthetical underneath it. And then if you were being referred to an orthopedic specialist, of course, and needed to get the bone removed, you do 26587. I went out on a date one time in high school with a guy who had an extra digit, and we went to the Memphis Fair. I don't know if y'all have ever been to the Memphis Fair, but it was a barbecue festival that they have every year down by the river. It's massive. It's huge. It's the biggest thing Memphis puts on every year. It's a barbecue festival. And I never forget it because I told him, you can't park there. Don't park there. And of course he parked there and got his car towed. Oh, men, never listen. Never listen. But every time I think or hear or an extra digit gets brought up to me, I think about that little kid and his extra finger, and him not listening to me and parking his car somewhere where, you know, he thinks he's going to get into the fair faster and not have to walk so far. Well, that's not how you do things. You're going to get your car towed. He got his car towed. I don't even remember his name, but I remember his extra digit. All right, let's see. What else? Does that help you with that extra code, that code, Charlie? Who else was, I was going to do something. Oh yeah, about if you are taking your exam today, tomorrow, this weekend, be sure you know these vocabulary words. Let me get my little document over here. Oh, where are we at? TRI. Be sure you know these vocabulary words. What are we supposed to be doing? AIDS, yeah, Trish, yep. Be sure you know what connects bone to bone, parts of the shoulder. There's 3 of them. Parts of the knee. Parts of the small or parts of the large intestines. JVD. What does a urethra do? SKENE, gland. And then is it male or female? Be sure you probably have at least one blood pressure diagnosis thing go on, like CHF with something, and they want to know if it needs two codes or if there's a combo code with it. You'll have a sepsis example. You'll have a burn, an injury. You'll probably have a adverse reaction, overdose, underdose. What else, guys? HIV and OB. Just find all the practice exam questions you can on those areas for guidelines and for diagnosis codes. I know we only have five questions for diagnosis codes, but sometimes they use these as some of your compliance or guideline questions. But those are my favorite areas that they usually always pick on. Of course, diabetes too, right? Diabetes, CKD, psych. They're going to have something, some sort of emotional reaction, probably on the exam of some sort. Just my favorite areas to be sure and study for homework. Just find all the practice exam questions you can in those areas before the weekend. Yeah, help out. Let me catch up on chat and see what's going on in there. You have a question about 29880. This is knees, right? These are the meniscus tears. And 29881, is that the meniscus tears? The one and an or? And that means, number one, let me see if this is where we're at. 2988. The main thing with these is there is a big difference, guys, in, where's my drawing tool? Okay. I don't know if I can draw a knee. We'll draw a knee. This is, oh my gosh. So this is a shoe. That's somebody's laces to their shoe. That's a foot. Okay. So this is their knee. When they're doing surgery on the knee, when you're looking through the example question, the route into the body might be lateral or posteriorly or whatever. They usually go in on the non-injured side. So when you're looking for key terms, one of the issues here is they might not be fixing the lateral meniscus, but they went in on the body on the lateral side, which makes you think that, okay, they went in laterally, blah, 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 with the trocar cameras, and then they fixed the medial meniscus. And then you think because they have the word lateral and medial in the question, you think they did both, but this one was just the route into the body. So pay attention to the wording before some of these in this musculoskeletal section. Make sure some of the words right before lateral or medial or posteriorly or any of those positional words. What's some more positional words? Make sure that they're not talking about the way they went into the body, because that's got nothing to do with the procedure that you did today and what you fixed. So that's key important for these codes. And what was her question about those codes? She put, I have a question. That was IBIS. IBIS. I have a question about block and block. Okay. She does CPB on the 15th. Lisa does. That's awesome. 819. And then Kathy has a question about 99151 and 99155. Is that the ones in the back in medicine with the same physician or other physician? I'll look at those in just a minute, Kath. But I think that's what that is. IBIS, one is medial, one is medial and lateral, and the other one is medial or lateral. Yep. That's perfect, Erin. Sorry, I couldn't locate migraine in the CPT book. Why would you look up migraine in a CPT book? Migraine is a diagnosis, and we'll have that in the ICD-10 book. But to look up migraine in the ICD-10 book is a hard one because they call it, it depends. You have to know what type of migraine. It's not like non-specific. We would be around like G43, and there's going to be a 9 something. It's going to end in a 9 for unspecified, but migraines will be around the G43 area. So that'll be in your ICD-10 CM book. What they have in the CPT book is like the electrodes or electronics or treatments like acupuncture, a burr hole if we have to cut into your skull, EEG to test, make sure you're not having seizures, that kind of stuff. It's all procedures. What does IBIS want to know about these? Okay, here. No, that's little Joe. A patient referred to physician by an ER physician today for follow-up for her fracture. Patient presents with sprint, unconscious and unable to walk. Review of systems that placed an ankle cast for the patient and follow up. Little Joe, that one, there's a guideline. So where are we at? We're going to have a guideline about that. I'm trying to find it. Where is that guideline? Dislocation fractures. Yep. Where are we at? Is it here? Oh, wrong book. I'm in 2022. No wonder it looks different to me. But we've got a guideline about if they present and all you do is cast them. So in the musculoskeletal system, in the guidelines, in the front, where is it at? Here we go, fractures. Okay. Second column of those guidelines start out with musculoskeletal system. Second column, the heading says report fractures or dislocated treatment. If a person, we're going to have something over here about casting supplies. Where's it at? There it is. It's at the top. Casting, splinting, and strapping used solely to stabilize a fracture for a patient. Comfort is not considered closed treatment. It also says that the treatment closed fractures, closed treatment. Yep. If MD does not document what happened in its notes, bill lesser service, default. We are just going to bill for those casting supplies. We're not going to bill for an E&M visit on that one. There's no full eval, like a history, physicals. We didn't look in their ear. We didn't listen to their heart. We didn't take a history. The only review of system was pain to touch of the ankle. So there is no ER visit that's going to be billed. All we bill is for that casting supply. No E&M visit. Nope. No ER visit. Nope. We only bill the CPT codes for the casting supplies. What did they use? Did they use fiberglass or plastic plaster? Hey, Go-Kart, good to see you. No E&M visit. None whatsoever. All right, 991, I think those are those medication ones in the back. 991. Five. Look at that recall. Got some recall. That's 3 sets of codes in a row. I knew what they were before we did anything. So what we've got going on here with 99151 means that patients are usually in the ER and we need to sedate them a little bit, like give them a shot of something to make them calm down before we manipulate a bone back into place, like a shoulder or a kneecap or something. So 99151 is the same physician that gives you the shot that pops your bone back into place. It was done with the 99151. The 99155 means it was an other than. Other than is the only word difference between that CPT code descriptor and this one. It says other than. That means even a CRNA, a nurse gives the shot, but then the physician or whoever else pops the bone back into place. So if there's two, if they're tag teaming the patient, you're going to use any one of these, the 5.5, the 5.6, or the 5.7, depending on patient's age and stuff. So that's a fun one. Fun one. And then the question about the musculoskeletal ones, of course, wherever that was. With the and or. Those are fun. They're so hard to get. Sometimes they'll say that they repaired the medial side, and then they'll have a few more sentences later on that says that they continued on and they ended up shaving a little piece or doing something to the lateral side. So be careful. They may not say that they repaired both in the same sentence. They may be sneaky about it and say that they did it somewhere else too. So never know. But if they only repaired one side, you're going to be at the 81. But just be careful, because the route into the body can be called lateral too. So that doesn't mean that they fixed the lateral side. That usually just means the lateral side wasn't broken, and that's a different way we went in. The migraine one, I had to look up. I used my trusty Google on it because I hate migraines. They have so many diagnosis codes for migraines. It gets really confusing because there's so many different types of migraines. The with and without, the aura, and the way they describe them in the questions when you have one on your exam can be very vague, and knowing which one you're supposed to code based off the guidelines. Just remember to always stop at the first 3 digits to get your guidelines for that. So what I mean by that is, if AAPC is going to test you on anything in this book and see what you know, it's what is written at the guideline part of each diagnosis. So each diagnosis, let me get this back on, has, you know, a whole set of codes. And then they'll start out and then they'll break down and get smaller and smaller and add extra things to it. But the rules for the initial onset of that particular diagnosis will always start at the first 3 digits. You won't find the rules that continue on for all the other diagnoses related to this anywhere else except for at the very first 3 digits. So as soon as my camera decides to focus here, sometimes if I write, it gets, it'll pick it up, but we'll see. Come on, there you go. It's supposed to be a teacher's camera, and it's supposed to do really good. So if a diagnosis is going to have guidelines and rules and tell you what to do, it's going to be at the first 3 digits. You don't go to the 0.9 or 0.431. You won't find the rules. The rules that they're going to ask you about are these red ones that say use additional code for the adverse effect. So if there is anything along these lines related, we need to use or use without or use with. This is what they're going to ask us about. So be sure and stop right there. Now, the non-specific one that I was talking about is way over here, almost 4 pages away, with the 0.9, but you know, we can't use that because we've got to go all the way down to the last digit. So the last thing we need to know from our example is, are we intractable or not? Would be nice, just in case if the example does have that intractable word in it, you need to know whether it's not or is. And this is where the migraine is. And then we still have to remember, you got to use an additional code, right? Just because we might pick unspecified, we still have that rule over there at G43 that says use an additional. So don't forget to use an additional. But the rule isn't here. The rule is way back here at our G43 plain number. So don't forget about that. What you can do is move this rule, use additional, to the code. That way you don't forget. And you can point to your rule that's going to be back that way. You could at least write it once on every column. That way, just in case these aren't the right ones, but then they ask about these, you don't want to forget about the use only. But if you write it once on every single column between here and the first original rule, then you won't forget. Anyway, just my suggestion. Anything else before we get started on questions for tonight? Got some lab and path. I hope that I have answered Ibis's question too. Check chat real quick. Hey Twinkle. Twinkle's giving away subscriptions. Oh yeah, somebody else has one. How do people finish the CPC exam in 2 hours and pass? Isabel, I have them routinely pass within 3 hours. I don't know about doing it in 2, but 3 hours and about 10 minutes is a good, really good indication that you did not read the questions, that you went straight to the answers, you looked up the differences between those answers, and only skimmed the question for just those differences. That's how you do it in 3 hours. You're welcome. All right, you have a question about 646. Six, 4, 6, 4, 2. Okay. And 4, 6. This is a really, 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 really good area to study for a medical coding exam, by the way. Yes, yes, yes. So she's 2 or 6. So one of them's an extremity, the other one is trunk. Pretty clear on our differences. Are we doing an arm and a leg, or are we doing your chest or back? What's your question about that one? Hey Courtney, be sure and let me know if you still have another question. Hey Jamie, thanks for joining the club. Who's winning all these? Oh, that was Twinkle. Twinkle gave away one. Zen won. Awesome. Hey, Jamie. It's good to see you. What was their question, Ibis, about those two? You have a question about 1700 and 1703. If you have 4 lesions, can I use the add-on code or X for the lesion? 1700, doesn't that do up to 14 or something? 1700, if my memory's working. I don't know if it's still working or not. Y'all, I'm so doped up on Advil and Tylenol. I don't know where my head is right now, but I'm trying. 1700. Where am I at? 1700. Oh yeah, burns are all in the middle of all this. I hate the way they set up the book this year. Okay. 1700. No. Yes. Destruction. First lesion. No, that's just the first. Okay. And then and then we had the times. Okay. So if you have 4 lesions, let me get to my drawing board. So if we had four lesions, our answer is going to look like this: 17000. This equals 1 lesion, right? And then we're going to add our 7003. It has the word each in it, which means you have to times for each additional one you have. So if I'm going to make something equal 4, how many am I going to times it by? I have 1, so if I have 4 minus 1 equals, that's how. I know the descriptor says something about 14 in it. It says second through. What I did was, that's misleading, and I don't know why they did that here. Every other example that is in this book that says for each additional lesion or whatever, I mean, even just right across here, they could have said for each additional incision up to 14, it would have made more sense than second through 14, because that makes you think it does all the way through 14. But it has the word each in it. And you see how each is one of the 5th word? Every other add-on code has each as the very first word. It's very misleading and unfortunate that they wrote it up like this. This means you have to code each. Each. You have to bill each, even if it's up to 14. So if I had 14 of them, I would bill the, oops, sorry, I'm drawing and y'all can't see nothing. If I had 14 of them, I would bill the 17000, comma, 17003 times 13. Now, when I get to 14, when I get to 99 of them, the only number that I'm going to code, if I had 99 of them, is 17004 all by itself, and we ignore these two up here now because we went over the number 14. If we do 15 to infinity and beyond, that's sideways, you know what I mean. We are only billing one code for any number of lesions after that. That handwriting is horrible, I'm sorry. But does that make sense? And what I did was I changed my descriptor here. I took out a line. I drew out second through because I don't want to see that. That's confusing. And I put up to 14 lesions, circled by each. Be sure you know the times. And then I have examples all over, like if I had 14, I don't think my example right there is 100%, but I've got, if I had 16, we're going to equal one code, 15 or more. If I have 99, I've got the same example right there. This is an example of 3 equals times 2. And I started to write an example for 14, but then didn't do it. But I'll eventually get that done. and my pen's not going to write 17003 times 13. But just write as many examples as you can find all around it. That way it's helpful for you for later on. Ooh, let me cover up the bottoms. No one wants to see that. Eamon, did that help? Yeah, add-on codes are very confusing. No, Melina, who, Melynna, she said, so code would read 17000 plus 17003 times 3. The 3 represents the 3 other lesions. Yes, yes, that's perfect. Sorry. The 3 other lesions, 4 in total. Yes. I have learned so much to watch your videos on repeat. Aw, you learn something new every time. Thank you. That's awesome. Last question. Can you bill benign lesions with precancerous ones? Nope. Not at all, because precancerous, yep, nope. Yep. So I really hate the way this book was done this year, because they really put the burn patients in between here when the burn codes are back here. It's driving me nuts. I really love the 2022 book and the way they had it done last year. Show you my notes, what I did last year for this area. If y'all want a copy of the notes, you know they're on my website. All right, what I did was I drew a line right underneath the 17004, this big long red line. Everything above this line is precancerous. Everything below it is benign. So if it's precancerous, it has to go up here. Here's benign. And then these, the last two, the 10 and the 11, these are like virusy lesions, warts and stuff. So they're not skin tags. They're still benign, but they are warts. So they're vascular. They have blood supply that go to them, and they keep growing and stuff like this. These, the 106s through the 108s, are birthmarks, like port wine stains and things that are birthmarks. So just kind of group them together, that everything above the red line is precancerous. These are birthmarks. These are vascular growth warts things. I like separating them out. That way you can think about them. I also, for this year, I went through and did a bunch of different names for the 17106s, like the port wine stains. They're also called the hemangiomas. A cafe name, the Mongolia thing, the hairy nevuses, congenital nevus kind of things. Just writing out all the different little examples. For the warts, we put plantar warts, the VV name for warts. Just finding all kinds of different names so that when you get an example on a coding exam, if they don't tell you it's a wart, if they don't tell you it's benign, and they don't even tell you if it's precancerous, you need to know the names of these things so that you can sort them and put them in the right spot. So the AKs, of course, are these first 3 codes. It's always going to say AK, always. And then we can name a bunch of the birth stuff, and then we can name all the vascular growths. That way we've got them all listed. Hopefully that helps. Oh, that's just my website. That's it, guys. If you need it, Medical Coding by Jen. There's a lot of free resources there too. If you click that resource tab and you go to CPT book prep, I have examples of how to book prep the ICD-10 and the CPT book for free there for you. Just click on the picture, it'll give you the instructions, tell you what to do. And of course the shop has them page by page if you want to just copy them. And also don't forget the little tab that says tutoring and workshops. I have a workshop coming up on the 16th of this month. It's a Sunday, if y'all want to join in on that too. All right, we got to get started on these questions for tonight. I hope that was helpful, and I hope I got to everybody's questions. Eamon, I hope that helped. All right, let's get to some lab and path, all right? Finishing up with the questions that we were working on. What is today? Today's Friday? Wednesday. All right, we're not going to worry about all the rest of these codes back here. Don't worry about all that mess yet. The first thing to do, and the easiest and fastest and most efficient thing to do, is just go look up your differences between these 2 codes. See what that difference is and check your question for that difference. That will help get you down to a 50-50 shot on this question. Super helpful. Try to take you like some index cards that are blank. I'm not saying the proctor will let you use them, but if they're blank, you have nothing written on them and you just want to use them as a blinder, you can let them know. They may let you use them. I've had a lot of people do that and they've not had any issues at all. Just saying, it's always up to the proctor what they allow and what they don't allow. You know right away when you see these 2 codes with the 00 in the middle, right? With lab and path. What have I taught you guys about this? When your second and third digits look like somebody's smiling at you, then you know you're in a panel. Those panels in the front of lab and path that are a bundle of codes, they always have the 00 as the second and third digit. So you know you'd be up here in these panels, and you can just be thinking about that while you're looking up the 844. Let's go look up the 844. So we're just going to put panel here because we're just looking for the main header. What's the main header differences on these? This is a panel. And what's our 844? 844. These are drugs, drug levels or hormone levels of some sort. 36. Thyroid. That's an individual thyroid test. So are we doing a panel or are we doing individual thyroid test? Let's check it out. Which 2 answers are we keeping? Where's chat? This is the last live you're going to catch. You take it on Monday. Oh my goodness. Yep, we're not doing it a whole individual panel because the panel includes more tests than what we need. So we know that we are just going to get rid of these two. Yeah. Now these have the same CPT codes. The only difference is now, are we going to diagnose the patient with 3 diagnoses or 1 diagnosis? Think about it like that before you worry about running to the ICD-10 book. What was the doctor's decision here to give the patient? Did they make one? Yep, the general health one does have a TSH in it, but they didn't order a general health one. With all those extra labs in it, all they ordered was a TSH and a T4. They did not add or bill or ask for any of that extra fluff that's in that panel. If the doctor didn't draw or order an albumin or the bilirubin or that calcium, and then the lab bills and does an order for that, who's going to pay for that? The coder, the patient, or the hospital? You know, you can't, you got to only bill what the doctor ordered, and that's it. Or you're going to be in a world of trouble. So you can't order more. About the only time that you can do that is if you're doing an infusion and the medicine only comes in 5 milligrams, but the doctor ordered a 2.5, you don't half bill the J code. You just bill the J code, even though you probably wasted half of the medicine or whatever, but that's super advanced, nothing that would be on the CPC exam for you guys. So what does the question say? It says the patient has sudden weight loss, rapid heartbeat, and nervousness. There was no other opinion from the physician at all, except for they suspected that the patient might have hyperthyroidism. Only if they're in the ER can you bill for a suspected diagnosis. We don't have any indication that the patient is in the ER, and that's per payer information, not really something we do that for the CPC exam. But just so you know, you can do a suspected, but only in the ER. Here in our pretend world of medical coding exams, we never code a suspected. So we're actually going to end up having 3. This is an unusual one where most of the time with AAPC, we usually end up just having 1 diagnosis, not 3. But this particular question, we do. We have all 3. One of the rare ones. Yep. What can I help you with, Mr. Travis? You're not going to come in here and harass me about pizza. I love you, but goodbye. I am sure you do. You haven't done one chore today. Not even one. Go put the towels away in the cabinet so that they look all pretty and everything. James took out the trash. James went and checked out the mail. Travis hasn't done anything but get flaming hot Cheetos out of Grandma and drink root beer.
I didn't ask for those.
Sorry, my child. Yay, Twinkle. She's giving away more subscriptions. Thank you, Twinkle. All right. Let's see about this one. These look like they're all in a row. We do have two of them with the same answer. It's probably just a difference between, are we doing a symptom diagnosis or are we doing a cancer diagnosis? And just seeing which one's in the question. But I know a lot of you say that during the exam, all the answers are in a row and you can't do the process of elimination. So let's go look up these CPT codes. 841. So we're really close to where we were. 84152. So our differences here, we have a direct measurement, or we have a total, or we have the free. Is our differences in these? Let's see what our question says. What do you guys think the answer is? Hey Deep, how's it going? Good to see you. What do I mean all in a row? Numerically, right? And our CPT book is set up to where all the codes are in a row. So every number is in numerical order. So 52, 53, and 54, all in a row. I have a lot of slang talk, I guess. A lot of your questions on a medical coding exam will be just like that. Do you know the difference between each one in a bundle like that? We got a lot of A's and B's. So first thing I notice is that the patient has blood in the urine, right? That's not cancer. I know anything with a C as the first digit in a diagnosis means the patient has cancer. Super easy to remember. We can get rid of those two answers right away. Now it's just a difference between the 52 and the 53. Which one has this wording in it? Because that's what we did. That's what was ordered. Which one matches? This one's got the direct, and this one had the total. So we know that B is our answer. Try to get rid of that. All right. Let's look up these. I like the 40 and the 45 because they are closer together than the 37 and the 20 numerically is all, but the 37 might be super close. Where are these codes? 88, 88. Oh, 40 and 45. I would probably just run to these two and see what my differences are. 40 is forensic, where 45 is a coroner. 37 is a single organ, just so you know. And then 20 is no nervous system. But I wouldn't even look them all up. I would have picked just these two, C and D, looked at my difference between forensic or coroner. I have in my head what my key terms are, what I would be looking for in my question. I would search from the bottom up to see what was going on. If it's a gunshot, I know which one it would be. What do you guys think? Self-inflicted or not, it doesn't matter. It's still going to be the same type of autopsy because it was a gunshot. Those questions. You probably end up having one. So just because a coroner was called doesn't mean it's investigated by the police. Coroners are elected people or people off the street who apply for the position. Many states, counties, don't require any education for a coroner. They just go pick up the bodies, and it's kind of crazy. So if it's clearly an accident, it would be D. Because there probably would be a police investigation, it's C. We need to make this one more difficult because it's got the word forensic in it. And that matches with what 40 says in it. But we should just have it like that because that'll make it more difficult. So what I put in my notes is on 45, I put equals accident. And then at 40, I put crime scene investigation by 40. Here we go. You probably get an autopsy on the exam. So be sure you know some of the differences in these. The differences between an infant we've got the difference between 88012 and 88025. It seems like they like to pick on those a lot. or the 88014. So be sure to know the differences in a lot of these. Try to find as many examples of autopsies being coded and then write out the examples near the codes. That'll help out a whole bunch. All right, musculoskeletal. Looking at these codes, I like everything that ends in 5, I would keep. And I would automatically get rid of A just because it ends differently numerically. Just looking at them as numbers, just because I like the process of elimination. You don't have to use it for your exam. It's just one of my tools that I like to use to help get me down to smaller set of answers faster. It is not 100% foolproof, but the rest of the steps does make sure that you are 100% correct, even if you do eliminate one of the answers, because we're going to check our headers before we do our descriptors. So if I go to 236, I haven't got there yet, 23655. Is that under the same header as, yep, we're all under the same header, which is a fracture or dislocation. 55 is a child code, can't do nothing with it. We got to go look at its mama. Its mama says that it's closed and it's a shoulder dislocation with anesthesia. Our 6-5 is also closed. It's also of the shoulder dislocation, but it also has an additional fracture of the humera, right? Our 7-5 is also closed. It's also of the shoulder, and it's surgical neck fracture. So it's probably a difference between a neck fracture or a humeral fracture, probably, if we're getting, they like to pick codes that are super similar. So just knowing that this is in the humeral fracture, this is a neck fracture, we just check our question, just look for that one word difference just to see if that shows up of any sort. May not. There is no additional fracture. Ooh, they made it easy. What do you guys think the answer is? Look at it again, go-kart. We've got a closed treatment of a shoulder dislocation with anesthesia, which is the only one that has the A beside it. There's no additional fracture. These two have fractures in them. And 50 has no anesthesia. And this one has the with anesthesia. There's no additional fracture. So we didn't need to go deep. I thought it might have been the 65 or 75. But no. But that would be an excellent exam question, by the way. If I was doing an exam, I would want to know if you guys know that 65, your one word difference is that humeral bone, and that 75, the one word difference is the neck bone. Yeah, that's a really good, I would love to write a question like that, because this one's really easy. Although I made it confusing because I kept talking about the fracture. E&M visits. Are we an emergency room visit? Is this going to be a hospital or observation visit? Are we going to be both ER and hospital? Are we going to be hospital or observation, admit and discharge all in the same day? So thinking about those scenarios, we don't do the process of elimination in E&M. We go on and see what our differences are in every answer. We think about those differences as we're skimming our question for our patient status. Where did our patient end up? What happened? Did they get discharged in the same day? Where are they at? Looks like they examined and gave orders, but I don't see any discharge here. That's my first thing I would think about because we've only got one code with discharge in it. So that would help me to eliminate one that doesn't have any discharge in it, right? So we can eliminate this one. Used to be in our previous coding guidelines before 2023, this would have been only the answer B. But now we're able to bill if the patient is in two different places. So we're able to bill C. We get to bill for the emergency room and for the admit. Both of them. The new guidelines indicate that the patient that is admitted to the hospital during a course of an encounter in another site gets to report both services. Now, technically, physically, the patient is probably in the ER, right? And they'll probably be there for a day and a half, even though they're admitted, waiting for a bed somewhere else in the hospital. So technically, physically, they may still be here, but on paper, they're here and here, and they get to bill for both, if that makes any sense. So patient status doesn't mean physically where they're at. It means billable charges technically are in two different locations. Another musculoskeletal one. I'm not going to do anything. Y'all are going to look up your differences between these codes yourself. Look those up. What is the differences between A and B? Let me know in chat what you think your one-word differences are. And then do the other two differences on C and D. Perfect. So we have both of these are closed. No manipulation. Positive manipulation. 16 is a treatment. With an implant. Totally different. Right? And our 77, where the heck is that thing at? These are under humeral. This is under proximal. There you go. They probably could get rid of this and just say with. Because even just taking out that word, locking screws, yep. Just to know you've got screws going in the body means you did an implant. You start seeing bolts and screws. You've even got a plate that was implanted, something, a graft. You have no idea. You don't even need the word implant in it. But yes, we are C. You're making these too easy. Ooh, these are all over the place. I see 2 of them have 5-4 as the second and third digits, but that B has 56 and D has 51. So I'd go check out the differences between A and C first. Do you guys know what the differences are? 2, 5, 4, 3, 1. 3, 1, and 40. Oh, they're right underneath each other. What's our one-word differences? Yep, that's all there is. So you're just going to look for carpal or scapula, whatever, scaphoid. Last word, carpal. You know right away which answer it is. Super easy. Twinkle giving out more. Super easy. Easy, easy, easy one. I swear I got some more difficult ones coming up. All right. We've got a difference between the 90s, and I'm talking about the second and third digits, and the 97s. Those might be under different headers. So where is our 290? $290.75. We're talking about, oh, there it is. Y'all know that guideline I was looking for today at the very beginning of our live. Somebody asked me, and I was like struggling to find the guideline. There it is. There's some more guidelines for casting and supplies, so be sure and know those guidelines. Anyway, would we be there or would we be there? And then our 97, where is our 97s? 97 is under repairs. 9705, this is under a repair. This is under casting supplies. See what we did to the patient today. We did a replacement. Thank you, Twinkle. If y'all want to win any of these subscriptions, be sure and hover your mouse over the blue box in that green alert that just popped up in your chat. If you hover over that, you'll see 3 dots show up. Click on that. Make sure you have the button pressed that says that you can accept gifts. If you've already got it done, it won't be there, so that's cool. But having that pushed will let YouTube know that they can pick you for a winner. Twinkle and I don't have any control over who the winner is. We just send the money to YouTube, and then YouTube picks the winner. So but thank y'all for all the thumbs up. Also, thank y'all for subscribing to the YouTube channel. It's free. Just click the subscribe button. I really appreciate it. And giving all the love back with the comments and sharing and letting me know how much it helps you. I know, these questions were easy. The lab and path were much more difficult. I'm surprised these are easier. These aren't easier. So we are not going to keep C and D, right? Because we did not do a surgery. We didn't do a repair, right? So we're only going to keep the casting supplies because that's all we did, right? So are we going to bill 1 code or 2 codes here? Where is your Q code? Where would that be? Yep, it's in the HitPix book. Perfect. Do we get to bill for both? We bill in 1 code or 2 codes based off this question? Oh, that's awesome, Alexis. That's great. Having your associate's degree is a great stepping stone too. So that's awesome. Good job, Nancy. Yep, we are going to bill both. I teach from the exam point of view instead of a coding point of view, indexing and all that stuff, which isn't going to help you during the certification exam. We don't index at all. I hate all this index stuff, but it's so unhelpful. And when you get into the real world and you start coding for a doctor's office, I haven't seen a book in the office in over 10 years. People don't buy these books for the doctor's offices. we use our EHR system, which is kind of like Google. We just Google cast, flexible, whatever, and it'll bring up a bunch of options. And it'll say, okay, did you do plaster? Did you do this? And we just kind of Google search it on our system. No one has these books, but that's okay. No man's land, I left out a word, is where? Where is the no man's land? Is it zone 1, 2, 3, 4, 5, TV, T4, T3, T2, T1? Where is the no man's land? Anybody know? You're welcome. It is hard with the boys. It is. But if you've already got your associates, then you can do like what's the name of that school? GS that college. I like it. Because you take one class for like 6 weeks to 12 weeks, and that's it. And then you take one more class, and that's it. Instead of piling on 3 classes, Monday, Wednesday, Friday, and then where you're taking multiple different classes during the week, this class has everybody do, this school does one class each week, and then you finish that credit, and then you move on to the next class and move on to the next. That college. Anyway, it's I like doing it that way, one thing at a time. And then if you could get you some buddies that are in that school for the same thing as you, those classes alternate. So as you finish one class, somebody else may have already finished that particular class, but you're starting on a class that they haven't started yet. Y'all two can swap notes and buddy up, and then everything that they have, that they've done, you can share what you've done with them, and y'all can compare notes. I love that school. It's great. I helped one of my friends recently get his master's degree in education. He lives in Arizona but teaches in California, and boosted his income. Yes. Zone 2, good job. Little Joe, you got that in your book. You didn't have to Google it. Perfect. Be sure, this is kind of helpful too, that tendons are separated into 2 types. There's flexor or extender ones. So when you're going through the book and you're making notes in musculoskeletal, pick you out a color for all the ones that are extender. You could circle in green, like, right? And then everything that's a flex, you can circle in purple, because they may say the same tendon in the same arm or the same ankle, but the only difference in those codes is one's an extender and one's a flexor. So, and it's hard to notice during the middle of a stressful exam, but if you go through and do color coding, I know all the purple are flexi and all the green are all extender, whatever colors you want to pick. It just makes it easier during the middle of the exam. Then you're not having to read the CPT code descriptors, and you can get through the questions faster, I think. It's just my way of doing things. Diagnosis codes. So what I like about doing diagnosis codes is when I have 2 answers that start off with one alphabet, and then I have another two answers that start off with another alphabet. My first strategy is to go see what my sidebars say for each one of those. So if I go into my book, what I mean by sidebar is if I go look up at anything in the S, doesn't matter where I stop, just as long as I stop in the S, they're color coded. All the S's are going to be this kind of baby blue. And on the side of any one of the pages, it says it's an injury, poisoning, or other consequences to external causes. You're going to mess up and going to find out. Area is what the chapter 19 is. So we've got injuries and poisonings. What does Q stand for, right? We stop at any Q, and that's chapter 17, but we just look at the sidebar, and this is congenital malformation. So thinking in my head, did they mess up and get injured, or were they born this way? That's the first thing that's going to get me down to a 50-50 shot on this question, and will make you way more likely to pass this exam your first try if you do these type of things first. So we separate them out. Are you injured, or were you born that way, right? Let's check out our question and see what our differences are before we even have to look up any codes, because if you're rushing to all these little tiny little digits, it's a pain to get there and read all those different descriptors. It's just slowing you down. Congenital is the very first word, so you know you can get rid of the injury ones right away. Now we just need to know, do we have one diagnosis code or two diagnosis codes? We have a congenital dislocation of the hip with a subpartial whatever of the hip. Where are we at? Q65. Remember to stop at Q65. Remember what I told y'all about looking for the guidelines? If there's going to be any, you stop at the first digits. Look for anything that's red. We don't have any red alerts. Nothing that says code additional. Nothing that's going to be use additional, like if it was this one. You see we've got red that says use additional. We don't have any red alerts. That's always a good sign that it might just be one code. So, but don't forget to stop before you go down to the 01 and then the 32. So our 01 is a dislocated, and it says unilateral. Yeah, we have right. A lot of things don't have a right and left. They don't have a bilateral sometimes, you never know. So when we switch over to ICD 11, we will, but for right now, sometimes we do have just unilateral or right or just left. Some things don't, some things do, you never know. And then our 3-2 differences is of the left hip. I like the way AAPC does their books because the one word difference in these codes is highlighted in green. This is right hip, this is left hip, and it's already telling us what our one word difference is. We don't have to update it, which I love. I wish our CPT book was like that. We would save us hours and hours of work. So the only differences in these codes is whether, see, this one's left and this one's right. And that's all we needed to do for a word match. You don't even have to worry about whether you have another diagnosis code or not, because the first code has such a difference that you have to know about that makes things a lot easier to deal with anyway. Right and left. Yep. We've got our B. All right. Are we doing an office consultation, an office new patient visit, an established patient, or prolonged service on this patient. We have a patient, 65, Medicare, seeing Dr. L for the first time at the request of Dr. J, her PCP, for a cardiology consultation. Patient presents with complaints of heart palpitations and shortness of breath and nausea. Dr. L examines the patient and sends his recommendations and a written report back to Dr. J. How are we going to bill this E&M visit? Yeah, should be. Don't we have the hand zones in ICD-10 or HIPICS? ICD-10 has one with all the PIPs and metacarpals listed, which is nice. Doesn't have the zones listed though, except for they're color coded. Like the top part is green. I can see where they're marking the zones. And you see they have the purple line, the yellow line. It looks like they're marking them, but they didn't label them as zones. I'm checking out the one in the HIPICS. Same thing. Yeah, it's the same one. In our little hand that we have in the CPT, I've drawn all over the place. Doesn't have the zones, but we can draw it in there too if we wanted to. But I like the one in the ICD-10 book. It's bigger. They made that picture so tiny this year. Got a lot of A's and B's on this one. Yep, we are going to do new patient office visit because they don't pay for consultations. Anytime they mention the word Medicare, you have to go off the railroad track and not bill for anything you want. I found a new scenario that I got to look up later on today that I thought was really cool. Something about a different level of trauma visit that ended up being like a HIPICS code. It's really interesting. Got to go look it up. Because, you know, we have level 5 ER. Well, what if you have a level 6 or ER visit? It's crazy. There's this HIPICS code you go for. But anyway, nothing that would be on the CPC exam, but I just thought it was cool. I got it copied. I got to go research it and see what it is. Probably be really good for COC question for those outpatient hospitalizations. All right. Got an office visit established and an initial hospital admit care? Would we be in critical care services? Would we be an emergency room visit? Or would we be a initial admit hospital? So Dr. B admits a 6-year-old established patient to the hospital from her office to rule out sepsis. The child has a large amount of gas in the bowel and no whatever, and the cultures are negative, and the baby remains with no fever for 48 hours. They will discharge them home. Almost looks like a observation for 2 days, but how would we bill this one? It might be listed in the orthopedic stuff. I'm sure the no man's land is listed. What was that? What's the... Let me see. I'm sure it's drawn in here too, actually, really. Oh, good Lord. Nothing but Batman comes up. How about we do zone 2 fracture? Yeah, no, I don't want to be there either. I want to be... That's subcutaneous tissue. I want to be... Yeah, I want to be in the M's somewhere. I bet inside these M's somewhere there is a picture of the no man's land zones somewhere. You know, we have all this orthopedic stuff in the front. Where's our hands? Where's our phalanges? Phalanges. Be sure to know where phalanges are too. I guess it's going to be in the S's, but I was trying to find something around the M's. That might be a better place for all that. We got S62 coming up for fractured fingers, somewhere around there. I wonder if S62 has guidelines. 7th character, traumatic fractures, the wrist, we're at the wrist. Hand level, no man's land, no pictures there. I have to research it some more. There has to be somewhere where it's listed in these 3 books specifically for them to have created a question on it. They don't just create a question out of thin air for no reason. You have to be able to find it in these 3 books because these 3 books are your Google. So I'm sure No Man's Land is listed here. Oh, I know what I can do. All right, let me tell y'all what the answer is to this one while I go find that answer. Now that it's already worrying me. This is initial admit hospital. D only. When a patient is admitted to the hospital in the course of an encounter from another one. What did they ask us? I thought we were able to do both. What E&M category would be reported? Admits the patient. We're only doing admit hospital care. During the course of another care, for example, her office visit, all eval and management provided to the provider in conjunction with the admission is part of an initial admit when performed at the same date of admission. This contradicts if they started out in the ER and then moved to the hospital admit. The problem is the beginning of this patient's visit right here in her doctor's office didn't rule out sepsis. They didn't do an evaluation and management. They deferred it to the admission of the patient, and that's when the doctor came in and did the full history, the full body exam. They just saw the patient in the office but didn't take a history or an exam and just said, go to the hospital, I'll meet you there for an admit. Patient looks too sick to even be seen in my office. If they had done a full evaluation and management, saw the patient, took the vital signs, maybe did a hemoglobin to see what the white blood count was, something like that, maybe even a chest x-ray, then we could have billed for both. This one did not have that evaluation done at the doctor's office, just sent the patient there, if that makes sense. Here's you another one. Y'all work on this one while I go do something else, because that other thing is driving me nuts, and I know I can find the answer. Let me see, can I find it in the ICD-10, or am I going to be looking in the HIPICS? So this one we have an adult brought in by EMS emergency room department, unresponsive patient. Patient was evaluated the blood sugars, and the ER doctor was unable to take a history due to the patient being intubated. Patient was examined, stabilized by the ER doctor, and transferred to ICU. The ED provided documents for total critical care time of 25 minutes. What E&M category are we going to bill for this one? Maybe it's something that's just in their study guide. That's not nice. What are you guys coming up with this one? E&M is tricky. It is a pain. No, actually A, I think, since CC is less than 30 minutes. Good job, Deep. Be sure to know that the critical care has to equal 30 minutes if you're going to bill critical care. You're correct there. I don't know if that's the correct answer. Got distracted. Let's see, where are we at? So we have 25 minutes of critical care. It's less than 30, so we know we can't bill critical care. We're asked to bill for just the ED provider. We didn't get asked to bill for the admission to ICU, right? We didn't, I don't know. Stabilized by the ED and transferred to, I wonder if he's responsible for the patient now that they're over there in ICU. Is still going to go see the patient or just transferred the patient? Depends on, I need more of the chart. Like, is there somebody else going to be assigned to the doctor? But it drives me nuts with this one. Because most of the ER doctors don't go up to ICU and see patients after that. They stay down in the ER and they just treat patients down in the ER. This isn't one doctor asking another doctor to see another doctor or see another patient. So we know it's not a consultation. Deep has passed her CPC. Good job, good job. Very recent. I think she ended up having 7 100s on her exam. You know, there's 17 sections on that lovely exam. She did really well. She's good. Not that she didn't learn everything she knows from me. I think she came to me knowing a lot. Answer is just emergency room doctor. Easy peasy on this one. Keep in mind that 30-minute mark. One of the questions they might ask you is if you look on page, let's see, I think it's around 40 something. Yep, 43. So if I switch this up and this patient had 30 minutes of critical care time, but they also had a endotrach tube put in. There's a list on page 43 of the CPT book. I think it's 52 if you're in the 2022. Wrong one. This one. But we're looking for this list. It's got a list of all these codes. This page is super helpful for during the exam because you will get a question of mixing some of these medicine codes in the back of the book with E&M during an emergency situation, and you need to know which ones you can bill for and which ones you can't. In critical care, if you did any of these during critical care and you're going to bill for it, you can't bill for it and also add the time that it took to bill for this into your critical care time. You got to take that time off, however minutes it took you to do it. You can assume it's 5 or 15 minutes. I'm still looking for a list of, like, I would like to know how much time do I take off for 36000 as an auditor, you know? How much time do I take off for an arterial catheter? How much is it? I don't know. 5 minutes, 10 minutes. Some endotracheal intubations happen in less than 5 minutes. But the staff sort of stops doing what they're doing. Like, they got to go get the tray. They got to unwrap the tray, do your sterile technique, hand you your tubes and your KY jelly and all this stuff, whatever. So they're all working on that endotracheal intubation with you. So critical care time stops, and we can't count it if we're going to bill for it. So some of them can happen as fast as, your brain stops. You got to get it down and get it going. You can't have 3 minutes, no oxygen, right? You're on a timer. But I've seen as much as people saying that you needed to take 15 minutes off. But my assumption would be 5 minutes. You can't take any longer than that. But I can't find a guideline yet. I haven't researched enough to see how much we take off for this. But anyway, in general, for a CPC exam question, we're going to take 5 minutes off or 15. So that means our total critical care time is back down to 25 minutes, which means we cannot bill for critical care, and it would go back to ER visit anyway, 99, 280, whatever it would be, 285, 284, whatever. Probably a 5 if you're dealing with life and death situations. But you probably might get an example like this on the exam where they tell you they had 30 minutes of critical care time, but they also were billing for one of these. Be careful, you can't bill critical care for that. And there is a rule in the middle of all these guidelines here between 43, 44, and 41 that says that. It says you got to take the time off. I'm writing all over the thing and y'all can't see none of it. I need a keeper. She said she learned it all here. Aw. Hey, Jada. You go Wednesday to take yours? Awesome. Oh, did she find it? 263. Let me go look. 263. I found, did you know you have zones in your spinal, your vertebral too? So there's zones in your vertebral thing. 169. I knew it had to be here somewhere. Two, 6, 3, 5, 6. Flexor, no man's land. Oh, it's mentioned in the little parentheticals, the things that I make y'all highlight. I got mine highlighted, but don't remember what the words were because I'm just going through there going. Yeah, I was just looking at diagnosis code S3212. They have a zone 2 fracture of the sacrum, and then you have zones, all in your sacrum. But if I go to S32, they don't describe what the zones are, and I wonder if there's a place somewhere in this book that describes where the zones are, because they have different zones of fractures. Anyway, that was interesting. But thank you so much, Twinkle. You rock. You rock, rock, rock. Keep calm and think what Jen would do. That's right. Aw, you take yours next Saturday online. What type of webcam should I buy? Cheap plug and play one. One with at least like a 5-foot cord not a 2-foot. Try to get one with a 5-foot. I managed with a 2-foot, but they probably wouldn't allow it that nowadays. Just any cheap one that you can find. Don't buy a stand for it. I had mine sitting on a stack of books in a coffee cup. It's just one test. Yep, my website, I've got all these pictures, guys. Free on my website too. If y'all go to the shared gallery, there is a ton of stuff. Let me sign back in. Ton of free stuff there for you guys that shows you how to get your ADA if you want an extra hour to take your exam, where to send your college records, like that associate's degree you've got. You won't have to do Practicode. You can submit that stuff now before you take your CPC, and you will not get an apprenticeship. Just submit that ahead of time. I've got copies of where I've submitted all my stuff, and my associate's degree was from 1994. They still took it. When I go live, there's some fractures, copies of the notes, just all kinds of stuff here. Here's the webcams that you're supposed to use from AAPC. What pens do I use? There's the ADA and where you send it. You can submit ahead of time to get your apprenticeship taken off, all kinds of stuff. And you guys can add to this right over there where it says add gallery. You guys can make this even better by adding your own pictures that you guys like in here to help out others. Super helpful. Don't forget to utilize the resource page. Go to the CPT book prep. There's even book prep videos there too. But you just click on the picture and then it'll give you the instructions on what I'm doing there and why I'm doing it. So you can make up your own notes if you want to. I don't know why it keeps doing that, but there's lots of resources here. Don't forget, under tutoring and workshop, I've got a workshop coming up July 16th. We're going to do anesthesia, the medicine section, and E&M, 3 hours. No talking and visiting, just back-to-back questions. We're going to do 75 questions in 3 hours, same pace as the exam. If you guys want to have access to it and watch the video as many times as you want within 90 days, it's just $12 if you want to do it. After 90 days, I will post it onto YouTube for the YouTube membership, of course. If you hover over social media, there's an additional educators tab here too. So there's other people that teach. This guy on YouTube, I've never seen any of his videos, but I hear a lot of people talk about him. And other people, as you people get really, really good at what you're doing, and y'all get your CPC and maybe CRC, and you want to further your career, this lady that does the coding guild, she's super advanced. Like, she's in the nitty-gritty of billing and stuff. She can way outdo me. She's got a lot of free questions and things on her website too. Ranty Randy, he's great on TikTok. He offered to help tutor people too, so you just reach out to him too. Pocket Prep is there. Just a lot of people that can help you out. I got digesting book prep videos there. The blogs are there, of course. I did one yesterday on some new revision codes that are fixing to come out in 2024. The new books will be here before long. October, they'll be out again. Oh my gosh. But I do have tons of notes and stuff if you guys want them. I even have just a new one-sheeter thing that, in case you wanted to just know how I book prep all the sections of all the book. That's just a one-sheet printer thing. We even have cups and mugs and stuff. So even socks with our little logo on it. Wrapping paper for Christmas. That's kind of fun. But I got to get me one of those license plates. I think that's cute. All for you guys. Let's see. Can we do one more question before we go? Maybe. Let's go look and see. I think I've got another E&M one. If anybody's still hanging out. I know it's late. This one was emergency. What about this one? We've got a patient had a consultation with Dr. S, a dermatologist, 2 years ago for a mole that had developed on his back, which turned out to be a compound nevus. The patient liked Dr. S and decided he wants to go back for a lesion on the face. The patient is returning today to see Dr. S for a suspicious lesion on the face. For the past few weeks, Dr. S examines the patient and performs some biopsies. What will Dr. S bill for today's visit? Office consultation, an established patient, an office new patient, or prolonged service? And let me get rid of the screen so you guys can see some of this question maybe. There we go. That may help. Let me get this up with that, and that way it can all be into one screen. Last one, and we'll go. I'll be back on Monday to do 2 more hours of Q&A with you guys. If I'm around this weekend, I will probably just be here working on this study guide I've been trying to do and make. I've got like the business of medicine sort of going and almost E&M. Well, almost. It's a lot to do a study guide of all the little things you might need. But then I'm trying to pare it down and make it just, okay, know this. Here's just some examples. And get rid of all the fluff. Because I find study guides have a lot of fluff in them. I know. I hope you get a job too. Deep, I've been posting in our Discord group a ton of jobs and other Discord people that are in the medical field that know where all the remote jobs are at and how to get on. There's this one girl who works 4 remote jobs at one time from her desk in her kitchen living room combo with the kids and the dog in the background. You should see that woman slide from one laptop to another laptop to another laptop to her desktop and then back down the row again. 4 at the same time. She's earning 4 salaries or whatever. Full-time, 4 salaries. No thank you, but she knows where all the jobs are at. So anyway, it's crazy. I've been posting them in our Discord group. Our Discord group is completely free, guys, and it's got 2 years of info in it. You can scroll backwards through. We got practice question rooms. We got resources for jobs and CEUs. Just tons of stuff. Y'all can share, all that kind of stuff. She's got all the tips for that stuff and how she got started. Some of it is just like, you know, if you have any customer service help at all, experience from any position, customer related, even if it's not coding related, you can still get in there because they have chat features where people need to take over chat conversations and help people with, why was I billed this? Why is this code here? Just checking patient benefits, seeing if they have dental services or if they have whatever. You could do it all chat feature. There's tons of jobs out there. I know that would get on my nerves too. I've done 3 jobs at one time. My full-time regular job and 2 contract jobs, one for a home health agency and one for a hospice agency. And I just worked on my lunch break or after hours and got it all done. It was fun. I made way too much money that year, and the IRS ended up taking all of it anyway. I only ended up making like a fourth of what my triple salary that year was because it put me in too much of a high tax bracket. It was painful. But I learned a lot. Yeah, a study guide, like $20. I'm not trying to, these $150 study guides, y'all are just needle and dimed to death. And if I had just the basics of what's going to get you through the exams, be a lot easier than these $150 study guides that are too wordy. I don't know, I'm trying. Which room? Well, it's called Job Resources, my love. Let's see. Where are we at? Discord. And, you just press those little bars at the top and you can go through the rooms. These are all the different rooms. And this one says Job Resources right there. This is that lady. She works 4 jobs remotely from home. Huh. She's crazy. Y'all gotta go see her TikToks. And then this lady just had a bunch of them, and it's United Healthcare, and there was no experience needed. $27 an hour. Yep. Just a ton of stuff. And you got all this stuff you can scroll back through. I've even got old employment exams back here. So some of the first people I ever helped pass the exam shared with me, okay, so-and-so wanted me to take a coding exam. I posted pictures of what those coding exams looked at. I even wrote up a huge thing right here about how to find another free course online that you can add to your resume to make you look even better. This SQL for beginners, if you took this course and put SQL on your resume, it just means that you can use Excel or something like that to sort patients' data. Super easy. It's free. It's from Microsoft. That's the Microsoft logo. If you take that course and then add SQL on your resume, people are going to hunt you down, child. People love reports. Anyway, I've got all these other Microsoft solutions and other classes. This one's to enhance your information and HIPAA compliance. It's another free stuff. It's all kind. I got so much stuff in here. So much stuff. But yes, I've got coding exams from other people who have tried to get on at other places. And ooh, those interview tips. Those interview tips. I don't interview well. I don't think anybody does. List of 25 companies that hire. but there is a ton of, there's the test. You can download them, open them back up, PDF. Remember, we're just sharing as an educational thing. We are not openly sharing this stuff over the internet, right? But super helpful. Let's see what the answer is for this one. We've got this patient who came in 2 years ago and is back again to see this specialist. It's just an established patient visit. Easy peasy, because we have our first guideline, which is if we've seen them, even if we saw them in the ER and we see them back in our regular office, they're still an established patient if it's been within 3 years. Now, next time, Monday, we're going to start working on what means a minimal or a low or a moderate or a high based off a note when you don't have MDM or time. We'll do some more of those. I have those coming up. So we'll do that on Monday. Give y'all's brains a break for right now. But I hope this has been helpful. It was so much fun hanging out with you guys on Friday night. I'm just checking out chat. This is part of my study guide. So like the third part of MDM is risk, and then I list out what risk is, and then we'll have some examples. And then this is the second part of MDM, which is data. And I even give you a little data sheet so that you can add 1 point for this, 1 point for that. If you have so many points, you're going to be one of these, right? And then another one for the problems, like if they come in. So your very first part of MDM, when you don't have time, is going to be, your first element is the number of problems. Well, depending on which kind, like we have one chronic or one, and then you can add them up, and then you'll know whether you're minimal, limited, and all that kind of stuff. So I don't know. It's still wordy, but I'm trying. I'm trying with the study guide, but I'm too much of an auditor that this is just going to sit here and get worked on forever before I'm ever happy with it and ever publish it. So I don't know. I'm trying, but I don't know. I don't know if I'll ever get it published. Y'all are welcome. Yay. Or Google. Yes, please join. If on my website, or even on YouTube, but right there on my website, up at the top, we've got Discord will be up here, and of course on YouTube too. In the very top of our YouTube banner up here, Discord logo, log on, is that little bitty corner right over there at the very top. I've got the link for Discord linked right there. Super helpful. You just have to have your own log on and password already set up for Discord. And then, yep. Oh man, we got 4,000 people that are members and 89 people are on right now. Very nice. Yay. And it's nice. You've got 4,000 people in there that can help you answer questions, especially when I'm not around. Plus, there's 2 years worth of info that I've packed in all those rooms. You can scroll back for it and find some really great information. All my brain is poured out into those things. All right, guys. I love y'all. Y'all have a very safe and fun weekend. I will be on TikTok whenever I can. I definitely will not be scootering. The very first day I got that scooter, what was that, like the 27th? It slipped out from underneath me, and I just fell on the, it's a basketball court, but did hit my hip. And I scootered for 4 more days and was fine. And then now I can't even walk. I'm like on crutches. It's killing me. But will I go to the doctor? No, absolutely not. But hopefully I can stop hobbling around this house one of these days and get my sheets and blankets washed. It's time to do housework. And I can't do nothing hobbling around here and can't put any weight on it. But that's okay. I can sit here at my desk and continue to work out some of this study guide. And I'll be on TikTok doing some lives working on the study guide if y'all are around this weekend. I hope to see y'all around. And yeah, we'll do some more E&M on Monday. Y'all have a great weekend. Thank you, thank you, thank you, thank you. I don't know why they don't hurt when you do them, but days later is when it hurts. It's like, really, I'd rather it hurt when it happens than wait and then think about hurting later. It's just a pain. It's inefficient. I want to know right then and there if I need to do something about it, not days later. All right, guys. I'll see you guys later. Thank you.